Everyone, today we'll discuss about X-linked agammaglobulinemia, that is Bruton's agammaglobulinemia. It is the common primary antibody deficiency disease. So it is the common primary antibody deficiency disease. Okay, going on to its genetics, it is as the name suggests, it is a X-linked. So, it is an X-linked inherited disease. Next, the abnormal gene here in this disease is present in the long arm of X chromosome. So, the abnormal gene is in long arm. This point is to, everybody knows it's a X-linked disease, so the abnormal gene will be present in X chromosome, but specifically it is in the long arm of the X chromosome. Okay. Next, the abnormal gene here is BTK gene, that is Bruton's tyrosine kinase gene. It is Bruton tyrosine kinase gene. This gene is crucial for the early development of B cell. So this gene plays a crucial role in the development of early B cell. Okay, it plays a crucial role in the early B cell development. Since there is a mutation in the BTK gene, so there will be a failure of B cell development. So that leads to mutation in BTK gene. It leads to failure in development of B cells. So the plasma cells, B lymphocytes will not be developed. But our T cells, the T cells will be in an increased percentage and the functions of T cell will be normal. But when we discussed Wiskott-Aldrich syndrome, since there was a defect in the T cells, there will be a disturbance in the B cell homeostasis. But here, B cell function will not affect the T cell, while T cell function will affect the B cells. Okay, so B cell functions will be normal. T cells function here in X-linked agammaglobulinemia will be normal, but B cells number will be less and function will also be affected. So according to European Society for Immunodeficiency, there is a definitive criteria for a patient to have X-linked agammaglobulinemia. First point is a male patient should have less than 2% of CD19 plus B cells. Okay, so a male patient with less than 2% of CD19 B cells. Along with this point, any one of the following. So any one of the following here includes: first, mutation in BTK gene. So you have to show the mutation in BTK gene. Second, or you can show absent BTK mRNA in northern blot analysis, or absent BTK protein in monocytes and platelets. Next, or there can be a maternal cousins with less than 2% of CD19 B cells. Okay, so the maternal cousins can have less than 2% of CD19 plus B cells. So these are the definitive criteria to tell a child is having a X-linked agammaglobulinemia. Next, we'll go on to its clinical features. So here the clinical features, when does this clinical features start? So most of the patient or most of the boys, they remain normal till 6 to 9 months of age. So they will be normal till 6 to 9 months of age because of the support from the maternally transmitted IgG antibodies. So with the support of maternally transmitted IgG antibodies. Okay, next. After this 6 to 9 months, they will acquire the pyogenic infections. So after that, they will start acquiring extracellular pyogenic organisms. Okay, so the organisms that can cause more frequent infections in these children are Streptococcus pneumoniae, H. influenza, Streptococcus pyogenes, and Pseudomonas. These infections or these organisms can cause recurrent infections in these children. So the infection these organisms can cause are otitis media, sinusitis, pneumonia, sepsis, meningitis. So these are the infections that these organisms can cause. So the child will experience the recurrent infection, and more than 50% of the children will have the serious infection by 2 years of life. Next point is the absent or atrophied rudimentary tonsil. Absent or atrophied rudimentary tonsil or non-palpable lymph node. This is the clenching point for the diagnosis of a child with X-linked agammaglobulinemia. Why this occurs? This occurs because there is a failure in generating plasma cells and B cells. So it occurs due to failure in generating plasma cells or B cell. Okay, so this is the clinical features in a child with X-linked agammaglobulinemia. Next, the lab diagnosis. So going on with the lab diagnosis, the B cells will be reduced. The child will have, majority of the child will present with neutropenia. Third, when you go for immunoglobulin study, there will be a pan-hypogammaglobulinemia. So all IgG, IgA and IgM, everything will be reduced. The B cells will account for less than 2% of the lymphocytes. T cell function or its number will not be affected. Then you have to do flow cytometry analysis. In flow cytometry analysis, you can find an absent BTK in monocytes and in the platelets. But in 20% of the patients, that BTK will be in a normal amount, but its functions will be reduced. For that, you have to go for genetic analysis. So genetic analysis is needed to confirm the diagnosis of a child with X-linked agammaglobulinemia. Okay, so this is the lab diagnosis. Okay, next is the treatment. So first, it's always a supportive treatment. So treatment of infections. Next, you have to give a long-standing prophylactic oral antibiotics for these children. So you have to give a prophylactic antibiotic therapy is required. So in prophylactic antibiotic therapy, we use oral cotrimoxazole at the dose of 5 mg per kg per day. The trimethoprim is used in the dose of 5 mg per kg per day. Okay, next. Replacement therapy with immunoglobulin G, IgG. So replacement therapy with immunoglobulin IgG is the mainstay of treatment, but most widely we use immunoglobulin therapy is being used. That is IVIG we use. So IVIG is used in the dose of 400 mg per kg is being used once in 3 to 4 weeks. Okay. Next, live vaccines are contraindicated in these patients. They should be given an annual flu vaccine. Must be given, or it can be recommended in this patient. So annual flu can be given for a child who is not having or not getting immunoglobulin also. Okay. So this is the treatment modality for a child with X-linked agammaglobulinemia or Bruton's agammaglobulinemia. So this can be asked as a 7-mark question in your university examination. Okay. Thank you. We'll see about the approach to a child with immunoglobulin deficiency or primary immunodeficiency disorder in the next video. Thank you.